what do we know about the virus? Where is it going? I know we're all wearing masks, and we're all supposed to wash our hands, and that seems about to be the only constant in all of this. Early on, I heard a report that it lives for 7 days on a surface, and then another report saying best ideal conditions 3 hours, and I just don't know where all this ends at this point. So I've heard so many disparate things in the last 6 or 8 weeks that I kind of want to know where are we now.
Well, viability outside the host is still a matter of discussion. There was that. I wouldn't call it an article, it was a preprint sort of thing that got published in the lay press about a little over a month ago out of the New England Journal. It was a study that used something called the Goldberg drum, which is this big cylinder, and they sprayed foam into it or sprayed mist into it. And in a sealed environment like that with no circulation, it remains in the air for several hours. If they put different kinds of things in there, metal or cardboard or whatever, it could, quote, live on those surfaces. It doesn't live very well. If you look at the numbers, it was from 10 to the third, 3.5 or 3.8 log order growth, 10 to the 10 to the 0.6, between 6 colony forming units, if you would call it that, or I guess maybe tissue plaque death sites per ml of solution. So really an infinitesimally small number of viruses. And this was a heavy viral load with a cycle frequency of about 20 to get a number of how many cycles of the PCR to detect the virus. So we don't really know in the real world how long we live on this countertop is the bottom line. And the CDC, I talked to Chris Hahn about probably 2 weeks ago, because we're still struggling with this, and people who have no symptoms who are still getting virus out of their nose 2 weeks later. But is that viable virus? We don't know that. Or is it just a fragment of RNA that they're shedding? And they're working on that now at the CDC to see if that has any actual viability or if it's infectious or if it's viral shedding of an incompetent virus, which is what we think it is. But we don't know for sure. So how long it lives on surfaces, we don't know for sure. I don't think it lives for days. It's a lipid envelope virus. It means it's pretty fragile. Nearly any decontamination product, soap and water kills it. And so it's not a super long-term virus on a surface, I don't think, but I can't quote you exact data. Just that one thing that showed up in the New England Journal, talked about 3 days on steel and plastic, maybe a day or so on cardboard, very, very brief surfaces on copper. It was only a couple hours. But a lot of that was, if you looked at it, it was based on a Bayesian model of viral degradation. They didn't actually sit there and culture stuff every 4, every 6 or 8 hours on those surfaces day in and day out. It was a mathematical model, so we don't. The bottom line is we don't know. We think the case fatality rate is about 0.5% across the board, and people that are hospitalized is higher, but there's a lot of people that are outpatients who don't get sick enough to come get into the hospital. So that makes it more lethal than influenza, but less lethal than some other viruses for sure. The first SARS virus in 2002 and 2003 probably had a 10% mortality, and MERS has about a 30% mortality. So this is more contagious, it appears, but less lethal, fortunately. Risk groups are definitely hypertension, diabetes and obesity, some degree of heart disease, probably heart failure, maybe New York functional class 2 or higher. People that have a pre-existing clotting disorder for factor V Leiden or prothrombin gene mutation or protein S, protein C, maybe anticardiolipin antibody patients, because what kills people is clotting. It's probably not the viral pneumonia. We're being more and more aggressive, I think, in the inpatient side and maybe a little bit on the outpatient side about anticoagulation in these people. I think my personal opinion is they all should be placed, if they're in the hospital, they should be on heparin, plus or minus some platelets. we've amplified in our clinic, certainly, I think everybody else, telemedicine has taken off like crazy. There are some people you can't do telemedicine with, right? They have to be seen. And what we've done in our office, at least, is to try and alternate with the provider a telemedicine visit with an in-person visit, telemedicine, inpatient, so we don't have, hopefully, more than 1 or 2 people coming into the reception area at a time. We try to room them immediately so that we don't have anybody in the waiting area, if possible. Masks, we all wear masks in the office now. We ask the patients to wear masks when they come to the office. If they don't have a mask, we provide them one. And then lots of hand washing, hand sanitizer. The question, what do you do in a room if someone has come in and they've left, they've got no symptoms, if we don't let them come to the office, they're symptomatic. Do we sterilize the room? We don't generally do that. Because I don't think we have enough wipes and stuff to do that on every single patient, every single room. We do a lot of in-office infusion therapy. In those patients, we do wipe those chairs or tables down because they're cycled like CL sitting there. So we don't take a lot of time to do that. We work to get those areas decontaminated if possible. We always call the day ahead of time to make sure they know they're on the schedule, first of all, and that they have no symptoms. And we remind them if overnight they wake up in the morning with a fever or a cough, call us and reschedule. Because just the fact they were okay the day before doesn't mean they'll be okay that morning. We know that people can carry the virus and shed it, potentially even high degrees of viral shedding for about 40 hours before the first symptoms appear. Or the peak viral load is about 12 hours before the first symptom appears. So an asymptomatic patient could be a super shedder, a super transmitter, and that's probably what's happened in some of the outbreaks around the country. But a mask will help that. If they come in asymptomatically, they're wearing a mask and they're washing their hands, they're probably not be shedding much virus into the environment. So that's why we think masking and hand washing is effective. What else? I think the social distancing and this shutdown we just went through has helped. Before we did all that, the numbers were climbing pretty rapidly, and I think that's blunted things substantially. What's going to happen this upcoming 7 to 10 days? We'll see. I think we're going to see a surge, not a huge surge. I think we'll have the capacity because we know what we're doing now, but we're going to see a lot more cases. I think we'll have kind of a dull roar through the summer, and then if they open football season, yippee-ki-yay.
All right. Does anybody else have any specific questions that be relevant for all of us to hear?
I have one question for Dr. Coffman. This is Dr. Negron.
Hey.
Hey, what is the rate, do we know, of people that are asymptomatic that don't express any symptoms? Do we know?
We don't have a great idea. That there was an article published about 10 days ago in the journal I'm blanking the name on. It was actually it was about what's going on in Idaho and Boise specifically. It took the numbers from Alphonsus Crush the Curve deal and incidence of positive antibody titers, and this is an accurate test. This is another thing that we weren't certain about how accurate the antibody tests were. It looks like the tests that they're using for this thing are probably in the 99% accuracy range. And so they had 1.75% of the testing, of the people that were tested in that, about 4,000 and some patients, 1.75% had a positive antibody. That's not a random sample. Those were people that were wondering if they could have had it, and they went in and got screened, and some did, some didn't. The people that had been known to be positive, the positive NP swab, they had 100% positivity, and then they had a negative control group, if you want to call it that, had a lower rate. So we think that the accuracy is reasonable, and we think that the background rate right now is very, very low. We don't have anything resembling herd immunity yet. I'm not sure how long that'll take, but it's going to be well. In terms of asymptomatic spread or asymptomatic cases, we think there's a fair number. I don't know if it's 50% or 10% or 20%. It's going to depend largely on the age. Older folks are going to have more symptoms. If they've got hypertension, they have a lot more symptoms. if they have hypertension and diabetes and obesity and, some degree of heart failure, they're going to be in the hospital. So we think that most of the asymptomatic cases are probably in people under 40, and children as well. Although there's a signal now about some sort of inflammatory condition that can occur in children, which can be pretty serious, but still it's a low number compared to the population base.
Anyone else? Any other questions?
Just therapeutically right now, we've got nothing to offer. We've got a bunch of drugs that we're trying. Remdesivir might work. I think we're still waiting for more data on that. In that NIH study, it cut hospital days from 15 to 11, and there was clearly a trend for lower mortality. It didn't quite reach statistical significance, but it was very, very, very close. So we've got some remdesivir. We're choosing patients who to use it on. Hopefully earlier rather than later. I think once somebody's on the ventilator, the cat may be out of the bag. But if we intervene sooner, I think we'll have better success. And there's a handful of other drugs like Actemra that are, biologics that might be beneficial to in some people. But I do think anticoagulation is going to be key.
Are they looking into hydroxychloroquine as a prophylactic?
I think that there's
coming into work today about a study.
There's a guy in Minnesota that's got, he was hoping to enroll 1,000 patients, either family members of positive cases, or healthcare workers with clear high-risk exposures. And his goal was to enroll 1,000 patients and put them on remdesivir. And I think he got to around 800 or so. And then somebody said something about it being a game changer, so everybody started taking it anyway. So we don't know. There's another study coming out of Washington looking at the same thing. We should have some data at some point. I don't know if it'll be another week or months from now. In terms of patients that are in the hospital sick with it, it doesn't appear to have much benefit. Yeah.
All right. Well, thank you very much, Dr. Coffman, for being here and bringing us up to speed on what's going on.